Thank you, David. That is a very nice and very highly praising introduction. I'll try and live up to the expectation. So thank you for joining this morning or afternoon or evening, wherever you are. I hope in the next 30 to 40 minutes, we can briefly talk about the initial therapy in metastatic disease as it pertains to GIST. Now, this topic is slightly challenging as I am speaking to a lot of you who are already quite well versed, but I think there is value in talking about, especially in terms of Imatinib and GIST, because this is, after all, our first line treatment. And as this technology becomes older, the treatment for this disease seems to disperse. So, if you look at the time of my predecessor, who was really involved in the registrational trials of GIST, the treatment is really being delivered at high throughput sarcoma centers, at least here in Canada. But nowadays, because this is considered, quite an established and old treatment, a lot of these treatments are done in the community setting. And sometimes there are some minutiae that is actually, how should I say it, overlooked or left out as a result of this type of approach. So I think, educating the public in terms of what Imatinib does in initial disease still remains important. So moving on, can you see my slides, by the way?
Yes, very good.
Perfect. So moving on, I've got some disclosures. I have a few research supports, not to me, but rather to institution. I also have got some paid consultancy from at least 5 different companies. But also, most importantly, I want to give slight credit to my predecessors, such as Martin Blackstein and Mark Verrill, as well as recent slide deck that was provided by Dr. Jonathan Tran, of whom you'll hear from in a little while. So I know this has been covered, but I would want to just cover this slightly to give context. And let's talk a bit about epidemiology and treatment history of GIST. So GIST, as we know, is a part of spectrum of soft tissue sarcomas. In fact, in many series, it is thought to be one of the most prevalent soft tissue sarcomas. It still represents a rare tumor, and it is a rare tumor involving the GI tract. The distribution is mainly in the stomach, followed by small bowel, as well as other parts of the GI tract. We think, and we now understand, that the stromal cells or the pacemaker cells of the gut wall is the origin of this tumor. There is similar gender distribution, and age range goes from teens to the 90s, with peak around at 60 years of age. As I said, it is a rare disease. The incidence is about 15 patients per million per year. In Canada, we have about 450 new cases per year. For the US, you could roughly multiply that by about 10 to 11 times. I think this number is quite correct if you pro-rata it globally. Prevalence is about 129 patients per million. Many of the patients, they do present with symptoms with this disease when it is diagnosed, such as pain, bleeding, and weight loss. However, about a third of patients may go on without symptoms, of which about a third of those 30% are incidental, and there is about 10% of patients are diagnosed on autopsy reports. In the metastatic disease, it's important to recognize that liver and peritoneum are the most frequently involved organs. There are other sites that can be involved, but they remain rare. Mostly, you could say liver and peritoneum are the 2 sites that are commonly involved in this disease in the metastatic setting. Now, in terms of treatment, if your disease is localized, surgery remains the gold standard. However, despite successful surgery, there are still many patients who suffer relapse, and there are ways to stratify the risk. The most recognized risk includes tumor size, location, and mitotic count. Our knowledge from this disease has evolved over the years, but if you look back in the 80s and 90s, before GIST is recognized as an entity and the pathophysiology has been recognized, we know in the advanced or metastatic setting, normal cytotoxic chemotherapy or radiotherapy is quite useless. So that's a picture there of doxorubicin. It's a drug that is very much recognized because it's red in color. It's used mainly in soft tissue sarcomas. And in the past, when we applied this treatment for patients with GIST, we virtually do not get any responses. Now, if you look back at GIST, and this is a slide courtesy of Mark Verrill, one of the people who trained me in England, he looked back at people with who are labeled as bowel soft tissue sarcoma, which is now recognized as GIST, and they look at chemo trials that involves these patients. And what you can see here is what we call a Kaplan-Meier curve, and this Kaplan-Meier curve is actually abysmal in terms of how the treatment benefits the patients. If you look at in terms of time versus the percentage population who are given chemotherapy with GIST, the median time of progression is 1.5 months, which is really 6 weeks. And in most chemotherapy trials, these are time points that represents the first scan, i.e. 2 cycles of treatment. Giving 1 cycle is 3 weeks. And you can see very few people make it to long-term survival. In the recognition of these numbers, and these are numbers that really sticks to mind, that in these patients, their median time to progression is 1.5 months, which is 6 weeks, and their overall survival, the median overall survival is somewhat around 9 to 12 months. And this is a figure that we should look at in a little while to see how the landscape of treatment with Imatinib have changed this disease completely. Now, in terms of diagnosis and pathophysiology, just in what it looks under the microscope, they can represent as spindle cells. So this is elongated spindly type cells, or they can present with epithelioid cells. These more rounded cells that you see, and sometimes it can be a mix of these spindly cells versus the epithelioid cells. Now, I think David touched to this in that the real hallmark of this disease is that it stains via immunohistochemistry with KIT or CD117, of which it appears it appears as a brown tumor showing a positive expression. And now we don't only look for KIT expression of CD117, but we also look for a protein called DOG1, and they are usually, when you have a co-expression of this, it pretty much clinches the diagnosis. Now, in terms of the tumor biology, we know that there are driver mutations that sets up this disease in terms of what it does. Proliferation, metastasis, and so forth. And the vast majority of the disease is actually due to a mutation in the gene called c-KIT. There are some others that are driven by other mutations, such as PDGFR alpha mutations and so forth, but they remain the minority. As I said earlier on, mutations are activating, and the growth now can happen without external stimulus, and I'll try and explain that in a little while. And these mutated genes, which then encodes for proteins, are then, targets for specific anti-GIST drugs. First of class of this was Imatinib. Now, what I meant by the KIT mutation is as simple as this. Now, this is a cartoon representation. So if you look at this layer here is the cell membrane. Imagine the KIT receptor as switches. There is an external switch and there is an internal switch. And whenever these switches are activated, what happens is that you get proliferation, survival, cell adhesion, invasion, and subsequent metastasis and angiogenesis. This process is actually energy-driven, of which you need an ATP binding site driving the process. But the bottom line is, GIST, what can happen is that these switches gets turned on without an external stimulus. So in normal physiology, you get an external stimulus in terms of KIT. Is yet another protein that drives this, and then it causes a downstream effect to cause the cycle that I've described earlier. But in GIST, we now recognize there are these abnormalities in different parts of the genes that drives the process without an external stimulus. Now, two of the most common mutations that you see in GIST involving KIT is actually exon 11 and exon 9, and these are worth knowing for obvious reasons later on. So let's talk a bit about metastatic GIST and Imatinib. David, I gather that in terms of this talk, the questions are towards the end as opposed to ad hoc.
Yes, but I'll collect any questions that come in off the chat, and we'll present them later. So far, no questions, actually, so carry on.
Okay. And the pace is okay?
Yeah, I think the pace is great. Thank you.
Okay, good. So let's talk a bit of metastatic GIST and Imatinib. So a bit about Imatinib. It is known initially as STI or STI 571, and it's got a trade name of Gleevec, and this can be spelled one of few ways. It is an inhibitor of many proteins, including ABL, BCR-ABL, PDGF, and c-KIT, which is why the interest arises in GIST. Is based on structure of the ATP binding site. Remember, I was explaining to you about the KIT receptor. It is energy driven, and it is the knowledge of the ATP binding site driving the process has helped us use this drug in GIST. This is orally bioavailable, meaning that it can be taken by mouth, and first in-man trials occurred in late 1998. And the context and the history of this, I think, was explained by David sometime yesterday. But in essence, to come back to the slide, the cartoon slide I presented earlier on, in KIT receptor phenotype, due to the mutations that we described, the ATP binding occurs and it drives the downward stream effect, such as that the tumor grows, invades, and metastasizes. But when you give Imatinib, this competes for the ATP binding site and blocks the downstream effect of cancer growth and progression. So Dave Tuvison, who is one of the first people who have shown the efficacy of this drug in the lab, and it is clearly exciting at this point because what we can see is if we have got a tumor with no treatment, tumor actually grows. But with even small concentrations of Gleevec, we get quite good suppression of the tumor, but with higher levels, in fact, tumor regression occurs. Now, this has led to a few studies. They are parallel both in Europe as well as in the US. I will try and present the data somewhat in a balanced way, but for early trials, I've taken the EORTC trials to demonstrate. So in the first in-human study involving Imatinib, at that point it was STI 571. The dose used in soft tissue sarcoma was in the range of 400 milligrams to up to 1 gram. 36 patients had GIST. There was a phenomenal amount of response, about 70%, with only about 20% progressing at 1 year. So if you remember the initial Kaplan-Meier curve that I showed, where people have got documented progression at 6 weeks, 50% of them had that at 6 weeks. Now we have got 80% who still not progress at 1 year, to show you how phenomenal the response is. This led to a phase 2 study. This is quite a smaller study compared to the American ones. Again, it shows quite remarkable features with a high number of patients with responses and progression-free at many, many months. We also noted there was very little activity in non-GIST soft tissue sarcoma, and the side effects seems to be manageable and tolerable, if you like. And we'll discuss a bit about the side effects later on as well. Now, this has led to phase 3 development of this agent. There were parallel studies in US and rest of the world, but that study doesn't compare to placebo or doesn't compare to chemotherapy, because at this point we knew that there was actually a very active drug in our hands. The question is, how do we deliver it? So most of these design were actually quite pragmatic. Doesn't involve placebo or a control arm that, that is non-Gleevec. So, mainly they are 400 versus 800 milligrams of Imatinib. And in the US study, there was about 746 patients, and the European study was 946 patients. But look at this, this was one of the most unparalleled trial in the field of sarcoma, where they recruited 746 patients in 10 months and 946 patients in 12 months. And those of you that know clinical trial and have done clinical trial will realize what an enormous endeavor this has been, and how rapid this has been accrual. In fact, I don't have a slide to show this. When we do studies, we have got projections on when a trial would end. These studies superseded it by about 1/3 of the time. They had standard endpoints, meaning that we're looking at survival benefit or progression-free benefit for patients across these two arms. Now, looking at the EORTC study, they took patients with advanced GIST. Now, the design is very similar to the American study, and it's randomized from 400 versus 800 a day. And there is a crossover design. It means the patients at 400, when they progress, they can go to 800 milligrams, and these can be in divided doses. When we looked at the responses, is quite interesting. Numerically, these are higher for complete responses, somewhat similar for partial response, and pretty much, again, similar for progression of disease. But these are not statistically significant. So we think in terms of a trial perspective, they are quite equivalent. Now, when you look at progression-free survival, there is some benefit to 400 milligrams twice a day versus once a day. The red line is the people who get twice daily dosing versus the 400, but this doesn't apply to survival. Now, what this study did, they then looked back at doxorubicin trials in soft tissue sarcoma as a demonstration of how efficacious this drug is. If you look at this, you remember I've said about 50% of people would have died from GIST in around 9 to 12 months, but you can see here that the figure is quite different. So at 12 months, there's well over 80% who's still alive without disease, and this tail goes on for many, many years. In fact, George Dimitri published a few years ago showing long-term survival in this disease, and it's quite astounding. So just to give an idea how revolutionary this drug is, and of course you may know, I think I saw it in David's presentation, that this drug made it to the Times front cover when it was released. But if you looked at all the studies, key studies that have been done, whether it be in phase 1, the parallel phase 2 studies in US versus Europe, as well as the phase 3s, you get a sense that when you treat people with Imatinib in the advanced disease, the vast majority of them would have a degree of response. That figure is somewhat around 50%, and another 30% or so will get stable disease. So giving you a figure about 80%. There is a small but definite number of people who get what we call complete response. They range around 3 to 5%, which means if you put the math together, there is about 1 in 10 people whose disease don't work. And this will be the focus of subsequent therapy later on, so to speak. Now, pulse on Imatinib response. So, there are a few things that are peculiar about Imatinib, and that was a steep learning curve, not only for patients, but also for physicians, because this is one of the first targeted therapies that we have used in sarcoma, as well as one of the first targeted therapies in cancer, period. So this is really a hallmark agent. If you look at example of response, there are some of them that could be classical. So this is an example of a patient with GIST. So if you can see my cursor, this light gray boundary here, this mass here is the tumor with a necrotic center, the darker bit. And when this patient is re-imaged some months later, you can see it has clearly shrunk. Now, there are some types of responses where it is a response, but you don't actually get a whole lot of reduction in size. So again, this is a patient with a picture of a tumor. You can see the outline of the tumor here, but here, although in terms of size, it hasn't changed, but you can see instead of solid material in the tumor, you have got almost like a cystic change here, you know, so it's fluid filled with that debris, if you like. So this is a form of response as well. In fact, this is one of the findings that have led to the understanding that size doesn't necessarily predict response in GIST patients. In fact, there are other criteria now, such as the Choi criteria, that looks not only at size, but also at tumor density. So, you know, the proof is in the pudding, is like in this particular case, and this is a case from we know that there is no evidence of active cancer ongoing. Now, this tumor can also be imaged by PET quite nicely. This is standards for some institution, not for all, and you know, in some countries and not in all. But if you can look here, the uptake of FDG PET is marked in this red area here. This is just excretion for the kidneys, so that's just physiological, and that's from urine. But this red material here that is right in the middle of the abdomen pretty much gets switched off only a month after Imatinib. In fact, there are some studies that shows that this turn-off effect, like it's as if you flick a switch, is present as early as 24 to 48 hours after starting the drug. In that particular series presented by Heike Yonsu, we also know that if you biopsy these patients before and after Gleevec, you can see the tumor cellularity goes down. Chi67, which is the proliferation index, it means how fast these tumors are growing, also goes down. So there's less brown material here. And lastly, the CD117 or the c-KIT expression goes down significantly. So it is showing that, you know, the drug does what it says on the tin, so to speak, in that it's supposed to block CD117 and drive the tumor down, and this does exactly that. There are some expectation in chemotherapy, for example, that the best response is seen at the first period of scans. So if you don't get a response in the first 6 weeks, it's unlikely you're going to get it at 6 months. Now, this is lesson number 2 for us, is that this is not true for targeted therapies. And in fact, in GIST patients, most of them, about 50% of people who gets a response by RECIST, meaning there is actually a shrinkage of the tumor, this is not really attained until months of therapy. So, you know, do not be disappointed if the tumors don't shrink immediately, because they can happen later on. But it's fair to say in about 50% of the people, they would have, if their tumors were to shrink, they occur around 6 months or so. In terms of evaluation, this is what we do in Toronto. It's every 2 to 3 months, and we can extend this over time. And I've got patients who are on, you know, on Imatinib for many, many years, that we're scanning them every 12 months at this point. But those are exceptional cases, and every time they are seen, they get history and physical examination. We do routine laboratory testing, not only for bone marrow reserve, but also for other organ reserves such as liver and kidney, because there are long-term implications. The standard test for us is abdominal pelvic CT with contrast. Usually this is triphasic. We use this not only at diagnosis, but also at staging, because we think this is still the best and most accessible tool to diagnose the sites of metastases accurately, such as the liver and peritoneum. Now, there are instances where we use FDG PET or MRI with gadolinium, but these are not routine for us. In fact, for FDG PET in Canada, we weren't, at least in Toronto, we weren't able to use it until recently. But the indications for this is that if there is solitary metastases, so it means if you get a solitary progression of your disease that you want to see and demonstrate in order to deliver some local treatment, things like FDG PET or MRI with gadolinium would be useful. Moving on. So as I told you, most of these tumors are driven by KIT, and are all KIT mutations equal? Because there are imatinib dosing considerations based on this knowledge. So coming back to this, remember this is a slightly modified cartoon. The main driver mutations are exon 9 and exon 11 being the most common mutation. And what we know from the 400 versus 800 disease sites, and I got to apologize, there are actually a slide of 3 slides that comes after this that didn't project well, so I just needed to remove them. But what we know is in people who have exon 9 mutation, they seem to derive a better response at 800 milligrams instead of 400 milligrams. Now, this has changed the practice between institutions. So, for example, there are some institutions that uses 800 milligrams upfront for people with exon 9, but not for exon 11. We here in Toronto and where I was trained in England, we take a more pragmatic approach. We start everybody at 400, and upon progression, we actually challenge them with 800 milligrams of imatinib. And the reason of which is there are people who are exon 9 who are actually sensitive to imatinib at 400 milligrams once a day, and we don't think something at 800 would be useful for those patients, given there are additional toxicities. But what I do in my practice in exon 11, I'm quite happy to start off with 400, but when you get an exon 9, you know, I do bring them initially to clinic a bit more frequently, and I scan them sometimes a bit earlier just to make sure that they don't have disease that's escaping from the suppression of treatment. And if there is demonstration of progression, I then increase the dose to 800 milligrams. Again, I'm just explaining this is because there's a huge variety of how we tackle this set of data in terms of how we manage our patients. I hope I'm clear about that. Now, how long to treat with imatinib? Now, the short answer to that as it stands today is until disease progression or intolerable toxicities or as per patient choice. But there was a French study that was led by Axel Lesesne who really addressed this issue quite well. So what they took was they took patients with advanced sarcoma and they were given imatinib at 400 milligrams once a day for a year. And at the point of 1 year, if they had responses, partial responses, or stable disease, they were then randomized to do one of 2 things. The first group is what we would have done normally. They were treated with Imatinib or Gleevec until disease progression. And the second one is the treatment was actually stopped. And then they were scanned as they would be in both groups. And at the time of progression, they were restarted on Imatinib. So what did the study show? It is very interesting. It shows, not surprisingly, when you stop, remember what I've said about the treatment is almost like you flick a switch off. So when you stop the drug, you've essentially flick the switch on. What happens here is that in people who are continued with the disease, they seem to have a progression-free survival of about 90% at 1 year. But look at this. At the point when you stop the drug, within 1 year, about 80% of people, 75% of people have relapsed. But these people who is represented in the orange line, when they are re-challenged with imatinib, do they do worse? Do they die earlier compared to the people who were continued on treatment? The short answer to that is not. So you could almost rescue them. So what is the take-home message? The way I see it is that I will not want to stop somebody's treatment willingly, meaning that, you know, unless there is severe toxicities or something like that, I wouldn't stop their treatment, even with the knowledge of knowing that you can rescue them later, because there is no way to predict what type of progression they would have. And if they develop a disease progression that is, say, rapid, or it will cause a decline in performance status, you may not have enough time to re-challenge them with imatinib. But if somebody has got to stop because of severe toxicity and you're thinking of re-challenging them later, this data somewhat supports that practice. Now, in terms of toxicities and dose management, how to take imatinib, let's go through that very quickly. They come in 400 and 100 milligram strengths. You take it with meal once a day with a large glass of water, as well as food. And it is important to recognize that imatinib is metabolized by the P450 cytochrome pathway and is mediated by two subsets of these cytochrome metabolism pathway, which is CYP3A4 and 3A5. And there are interactions with other drugs. So one of the best advice you can give somebody with GIST when they have been prescribed by this is to actually go through their medications and double check for the drugs that they are on. The common drugs that can cause problems are anti-cholesterol drugs. Many of them react with imatinib, so it's worthwhile to check. The other one is not probably from the CYP3A pathway viewpoint, but there are a lot of people who are on acid-reducing agents from their physicians, and they may also alter the metabolism of imatinib in terms of absorption. I would never start anybody with imatinib without our pharmacy going through their list of medication and doing double check of interactions. This is one of the key points when patients have been treated in community that is missed. So I think this is a very worthwhile take-home message from a practical standpoint. In terms of side effects, at 400 milligrams once a day, the most common problem that people complain about is edema, followed by fatigue and a host of GI problems. Edema is very prevalent and is very common. In fact, in a waiting room for sarcoma clinic, you can almost identify who's on imatinib versus not due to their periorbital edema. But generally speaking, although these host of side effects are present, they are not present in severe grades. So in terms of severe toxicity, that rate is still small. But this sometimes is a flaw on how physicians look at toxicities, because we grade them. We always make the conclusion when we see a slide like this, it is tolerable, but to me, tolerable is what the patient says. And sometimes that is somewhat lost in translation. For example, grade 3 diarrhea means going to toilet more than 7 times than what you're accustomed to. It means if you're 6 times, they go under this lower grade band. But if any of us were to go to toilet 6 times a day with diarrhea, to me, that's not tolerable. So again, we have got to be reasonably careful extrapolating this data, meaning that we know in terms of life-threatening or serious toxicities is low, but in terms of tolerable toxicities remain on an individual basis. And this has got to be interrogated at each visit, so to speak. Now, you know, if you remember, I said my approach, both as I was trained in the UK as well as here, is that we took a pragmatic approach, starting people at 400 versus 800, unless we'll use 800 unless we have to, so to speak. That is because the host of side effects, such as the swelling, the anemia, the rash, fatigue, and so forth, is much more, not only numerically, but also statistically significant when you compare them side by side. In terms of interruptions of dosing as well, you know, you get more interruptions at higher doses, and they are mainly due to not only hematologic, but also non-hematologic events, which is usually the main culprit in terms for dose reduction and treatment interruption. What is interesting, and this is the other reason why I don't start off at 800 compared to compared to other institutions, is that if you look at people who get dose reduced when they are started at 400 upfront versus 800 upfront, that is actually higher in the 800 upfront. But if you cross them over, it means you have somebody who's 400, then you increase them to 800 at the time that they need to be. That number of reduction, if you add the first column to the third column, is still lower than starting at 800 upfront. I hope I've made myself clear for that. So in terms of selective toxicities and management, so these are just some pearls of practice, if you like. For GI toxicities, we sometimes ask the patient to take their dose at night. We support them with antiemetics. For nausea, there might be the need for anti-diarrhea medications and a variety of those. And sometimes we split the dose if needs be. Cramps or myalgia, which is a common problem, is we ask them to increase fluid intake, salt supplements, tonic water without the gin, hopefully, and analgesics. Sorry for the spelling mistake. One patient have said Gatorade helps. I think that is just because of salt supplements in Gatorade, but I've had since a few patients who swears by it as well. In terms of rash, you may need topical medications, usually in the form of low-dose topical steroids. And if high-grade toxicities or intolerable toxicities occur despite the supportive management, we will then need to hold the dose and possibly change the dose at a lower dose level upon reintroducing it. So in terms of disease progression beyond Imatinib, this is a scope for a talk for people after me, so I won't go too much, but it's important to recognize the different types of progression. So if you take an example of this cartoon, we got a tumor that is diseased by GIST, you give them treatment, they sort of liquefy, they become dormant. When they progress, they can progress in a number of ways. They can progress in just a new site by itself. They can present as a new disease within an old site, or disease within the liver that is widespread. So remember, I said in the past, I've used CT mainly, but I use MRI or PET to diagnose these type of scenarios. So if you get a new site that is not previously there, or it is there previously but nowhere else, probably this type of investigations is very useful to denote what the true progression is in the patient, because it changes your management. So in terms of if you have limited progression, it means just one new spot or one new spot in an old spot, you can employ a number of treatment modalities, including resection, very rarely radiation, but also we can use chemoembolization or ablation. In widespread progression, this is when I increase Imatinib to 800 milligrams once a day, and subsequently, if that fails, there are a number of treatments that we can give. At the moment, we have access to Sunitinib and Regorafenib, and this is fully funded by the government here in Canada. Again, sorry for the spelling mistake there. We do get Avapritinib via open access, and if you have the D842V variant, we do get Avapritinib via open access as well. And we have a host of clinical trials beyond this, as we have a large phase 1 program within our institution. Now, off-label drug and use on non-KIT mutations. Now, this is explaining the 5 or 10% of disease that is not driven by KIT. It's fair to say that, in terms of off-label use, in terms of GIST, in terms of if you're trying to target KIT, there's a host of drugs that you can use. These are all modest in terms of benefit, because these are usually used in people who have usually been exposed to Imatinib. In terms of for non-KIT mutations, again, I've just listed this, and this is a slide deck that hopefully will be shared, and you will have access to this. Of course, for PDGFR D842V variant, which is highly resistant to Imatinib, you can either go onto a trial, or we now have got access to Avapritinib. the crinolinib study has been completed, so I don't know whether we can have access to that. Oops, sorry. In terms of SDH deficient tumors, we usually use either sunitinib or regorafenib bypassing imatinib altogether. At the moment, these patients are still recruited to the INTRIGUE study within our institution. And there's a host of molecular abnormalities that we can try and interrogate these drugs. None of these, in terms of SDH mutation and downwards, none of these are fully explainable by clinical trials, apart from one, because the crack fusion is actually histology agnostic. About 5% of the people who are so-called wild type GIST may harbor a crack fusion. So this is our strategy here, is that when we see what we think is a wild type GIST, open and close inverted commas, and that's really defined as non-KIT, non-PDGFR mutation within our institution, we do check for crack fusion. For KIT-resistant mutations, such as exon 13 or exon 17 mutations, there are now a host of drugs that we can try against this disease. But I don't want to get too much into this because I think this is covered by other speakers within the session. So some take-home messages. Imatinib still remains first-line therapy for most advanced GIST patients. You do need certainty in diagnosis, meaning a pathologist with specialty in GIST or sarcomas need to really look into this disease and make the diagnosis. And you know, the aid of his immunohistochemistry by CD117 as well as c-KIT is very helpful. Mutational testing, in my mind, is a must because it just changed treatment decisions. Dose escalation of imatinib are needed in certain circumstances. I wouldn't start it with upfront. Treatment till widespread progression is still the preferred therapy. And it's important to remember, although it's generally tolerable, treatment breaks or dose reductions may be needed. And what is tolerable from a physician's standpoint may not be the same from the patient's standpoint. And that bridge must always be connected, if you like. Any questions at this point? I'll be happy to take them. I would like to say thank you for the opportunity. I put some pictures there just to denote our team. This is just a part of a small team, but you know, my computer crashed a few months ago and I've lost a lot of pictures, but these are some that I was able to salvage. For those of you who don't know what I look like, I'm the big guy who's always behind at the far end. And if there are anything that I can help with, please let me know. Thank you.